Good afternoon, everyone, and thank you for joining us today for our second workshop for this rulemaking. I'm Amelia Boyd, and I'm the Program Manager for the Medical Commission and the organizer for this webinar. The meeting is being recorded and will be made available sometime next week. The documents which will be discussed here today are available on our website, which is wmc.wa.gov. All attendees are muted. Panelists may unmute themselves and share their webcam. Attendees, if you have a question or would like to make a comment during the discussion items on the agenda, please use the raise your hand function. You may also put your question or comment in the chat, and we will get to those questions and comments as quickly as possible. So I will begin the roll call of panelists and staff. When I call your name, please introduce yourself. So first, Kyle, if you would go ahead.
Good afternoon. My name is Kyle Kiernan. I am the Executive Director for the Medical Commission.
And Mr. Lopez.
Sorry, I was on mute. Ed Lopez, and I'm one of the medical commissioners.
And Heather is here somewhere.
Yeah, Heather Carter, Assistant Attorney General, Legal Advisor to the Commission.
And then Dr. Jager.
Hi there, Dr. Jager. I'm one of the Medical Commission members as well.
Then Dr. Murphy, if you would go ahead and please introduce yourself, and then you may start the script.
Good afternoon. My name's Dr. Terry Murphy, and I'll be the presiding officer for the Rules Workshop. I'm a commissioner for the Washington Medical Commission. Today is Tuesday, June 4th, 2024, and it is 3:36 in the afternoon. This meeting is being held via Teams webinar and in person in the Department of Health Town Center 2, room 153, located at 111 Israel Road Southeast in Tumwater, Washington. The rule being discussed today is regarding the general provisions for opioid prescribing and tapering rules for both the Chapter 246-918 WAC for physician's assistants and Chapter 246-919 WAC for physicians. Ms. Boyd, please provide some background on this rulemaking and explain why we are holding this workshop today.
So real quick, Fatima has asked that we pause for one moment after the introduction.
Hi, Amelia. Can you hear me okay?
Yes.
Okay. So actually, I just had a Kristen Brewer from the AG office come in person. But she went home because she said that would be easier to take the meeting from there. So I'm just wondering if you could forward the link to her email.
Yeah, I can try to do that.
Okay, thank you so much.
Sure.
Yeah, that's all I had to say. Thank you.
Okay, so in 2022, the Centers for Disease Control updated their opioid prescribing guidelines. And the WMC contracted with Gregory Terman, MD, who is a former pro tem member of the commission, and he is also a professor of anesthesiology and pain medicine at the University of Washington, and asked him to do a comprehensive comparison of the commission's opioid prescribing rules covering physicians and physician assistants to the guideline. Dr. Terman was also asked to recommend changes to the WMC's opioid prescribing rules based on the differences found between the opioid prescribing rules and the guideline. Dr. Terman provided us with a report, and then based on those recommendations in the report, in 2023, the commissioners voted to initiate rulemaking on the following 3 items: exempting patients with sickle cell disease, state and rule that not all chronic pain patients need to be tapered off opioids, and then clearer rules regarding biological specimen testing.
So first, we will discuss the draft language and the suggested changes from the rules hearing that was held April 26th of 2024. And is that what you just said, Amelia?
That is the first thing up for our chat. Yes, let me pull up what I'm going to be sharing here. So at that meeting, at that hearing, there was some discussion about removing biological testing from the periodic review chronic pain sections of both the MD and the PA chapters. And basically what was said is that we need to leave it in because it can cause some issues around when they should be doing biological specimen testing, and removing it from there may signify that they don't need to do the testing. So that was the discussion at the hearing, and the rule was not adopted that day because of this possible change.
So now the suggestion is to put it back.
Right, to just keep it.
Yeah, I looked up the definition of biologic specimen testing. It's very broad. It's very all-encompassing, and I think that speaks to the benefit of reinserting it, not removing it.
Gotcha.
I understand that.
Do the other commissioners on the panel have any other thoughts about that change?
I agree with what Terry was saying.
I agree as well.
And we have at least one person from the Attorney General's office. Would they like to weigh in? Heather?
Yeah, so this is Heather. I think the comment came from your AAG prosecutors, but I believe the thought was that in removing it, it would make it not a mandatory thing, which it's just saying this is one tool you can use, but that it could impact your prosecutions of opioid over prescribing.
Any other thoughts? So it seems that there's consensus among the three commissioners to reinsert it. Amelia?
And we can do that.
So are there any other comments in the chat, Amelia? Or shall
Not
we?
related to that change, no.
So we should move on now to the written comments. Keeping in mind, this rulemaking is narrowly focused on 3 items. Number 1, exempting patients with sickle cell disease. Number 2, stating in the rule that not all chronic pain patients need to be tapered off opioids. And number 3, clearer rules regarding biologic specimen testing.
So here's so in the packet that you received and that is posted on our website, we received several comments over the last 9 months or so about this particular rulemaking. And so you can discuss those now if you would like, because if we wait until the hearing to discuss them and decide to make a change, then we have to go back again to the 101. So and I had requested that you read them before this meeting. If you don't want to address them as part of this rulemaking, you don't have to. As Dr. Murphy just said, we are doing a focus rulemaking with this. And so if the suggestions or comments don't have anything to do with those three pieces, then we don't have to address it and can't address it as part of this rulemaking or make any changes based on the comment if it doesn't affect the three items that are in this rulemaking.
This is April. It seems to me that though the comments perhaps bring up some very valid points, and particularly the question regarding why just sickle cell and not some other diseases that have known kind of chronic debilitating pain associated with them aren't included, are very valid, but that's not the intent of this focused rulemaking. So if that indeed is not the goal of our focused job here, then it is something that should probably be set aside for a larger review, larger panel at a later date.
Right. We would have to do like a bigger rulemaking initiation to include, you know, some of the points that are in these comments that don't have anything to do with this particular rulemaking. So the commission would have to approve that.
So that goes beyond the scope of this meeting from what you said, Amelia,
Correct.
because I think we all noted there were some very valid points on bigger issues. But it's not within the scope of this rulemaking that we can even address them at this time.
Right.
Okay.
And if that is something you want to pursue, you can just let me know, and then we can present a memo to initiate rulemaking on other sections or some of the same sections at a future business meeting.
What would the commissioners say?
I mean, to me, that seems like a worthwhile discussion, at least. From a policy standpoint. I wasn't part of the original discussion that sort of chose to do what we're doing right now, at least on a focus level, but it does seem like perhaps it's worth re-evaluating that.
And
Mr.
I would agree.
Lopez?
Yeah, and I would agree. I think it warrants a full and reasonable discussion, not in this venue.
Yeah, and I think what I recall from Dr. Turman's review and how sickle cell disease was the one exemption that was listed is that it is considered a fatal disease, not cancer, that involves a great deal of pain and thus should be treated separately. So Amelia, if we could just put that item on a future business meeting to discuss with the larger commission.
Absolutely.
I think the multiple people that have submitted comments will feel heard, that it's not being dropped, but understand that we can't address it specifically during this hearing.
Correct. Okay. So was there any particular comment that you wanted to discuss from this batch of comments that do pertain to the items that we are talking about today?
I don't recall any one particular comment that I felt like needed to be addressed for my review a few days ago. I'm not sure if the other commissioners had any in particular they felt fit our limited scope to discuss.
I certainly didn't see anything dramatic other than, you know, the comments appeared to be heartfelt, but can be, I think, can wait for, again, an appropriate and more appropriate time and place to give those comments the time and thought that that those comments do deserve.
And I would just like to thank everybody for taking the time to comment. There were a lot of heartfelt and personal stories, and we hear you. And it will be discussed at a future business meeting with a larger commission as the rules dictate.
And
Amelia?
we received one additional comment
Okay.
today. Get it pulled up. And it is from Maria Higginbotham, who has come to business meetings in the past to speak about this. So I'm just going to read this
Please.
because we just got it. So it says, my name is Maria Higginbotham. I'm from Gig Harbor. I applaud the efforts the WMC is making to ensure Washington patients suffering in pain receive adequate and accessible pain treatment. Since the 2016 CDC opioid prescribing guidelines were issued, many state medical boards, physicians, hospitals, insurance companies, and pharmacies have implemented policies based on a, quote, guideline that have adversely impacted patients suffering in pain. Many physicians have forcibly tapered patients. Many have stopped treating pain patients, and others have just quit practicing. This has left millions of pain patients without care and forced them to choose between a life in agony, alternatives such as street drugs, or suicide. The WMC's adding an exclusion for sickle cell patients is an important step forward to ensure those who suffer pain from a rare disease have their pain treated effectively. I would like to mention that according to the CDC, sickle cell disease affects approximately 100,000 Americans. I would like the Commission to consider adding one additional exemption, rare diseases. According to the FDA, there are over 7,000 rare diseases affecting more than 30 million people in the United States. Many of these diseases are life-threatening and most do not have treatment. According to the Orphan Drug Act, the definition of a rare disease is a disease or condition that affects less than 200,000 people in the United States. Most rare diseases do not have FDA-approved treatments. I would like to ask how the WMC will ensure that physicians acknowledge these changes. Again, I respect the work done by WMC to entangle the issues brought forth by the 2016 CDC opioid guidelines. Every person will suffer in pain sometime in their life. Pain does not discriminate. Regards, Maria Higginbotham.
Thank you. Was that the only comment received today?
Correct.
Okay, so if that person is attending or listening, I hope they understand that we can't discuss that today, but it will be discussed at a future business meeting with a larger commission, and you have been heard. We appreciate your comments today. Any other comments, Ms. Boyd?
There are no other written comments.
Any further discussion or questions?
Go ahead, Hillary. Did
You may be
accident-
muted.
Sorry,
Did you
thank you.
There you go.
Thanks. So Hillary Norris with the Washington State Medical Association. I just wanted to ask quickly, generally are the PA and physician rules, they're mostly just supposed to be lining up with this rulemaking, like there's not a major divergence with the two?
Correct.
Okay, perfect. Thank you. I just wanted to clarify that. Thanks so much.
Yeah, they just have different numbers, but otherwise, when you read them in the WACs, the wording is not just similar, it's identical.
Perfect. Thank you.
Thank you for your question. Any other questions?
Well, I just saw that Kristen popped in from the AG's office. Kristen, did you want to speak?
Hi, Miss Brewer.
Hello, I'm sorry. I went to the live event and found that there was no live event, so I hurried back to my office. So I'm just now tuning in. I did have a comment about the urine drug screening and what should happen with an aberrancy, but I don't know if this is a good time to talk about that.
Absolutely.
Yes, go ahead.
Well, I noticed in the draft rule, it was proposed to eliminate that as one of the things that a practitioner should do, or in their pain agreement, was to have an agreement with the patient, and that a dirty drug screen or an inconsistent urine drug screen would have a consequence. And I think there was a concern that practitioners may over-respond and simply basically kick the patient out of the practice on one dirty screen. So in the portion of the rule below where it talks about what to do about that, I didn't have a problem with that, but deleting the urine drug screen as something that is a tool that should be used, I thought was a step too far, in that it's kind of seesawing practitioners who are trying to do responsible opioid prescribing, doing urine drug screens, and then following up with the patient if there is an inconsistent result is important. And it's something also that when we review a case can jump out as problematic, for there to be patients with inconsistent urine drug screens with no follow-up. And so it's a big gap between no follow-up versus necessarily automatically kicking a patient out of the practice.
Right. And I'm sorry for the confusion in where the meeting is taking place and how it is remote. So the part you missed was we reinserted the biologic testing. And then there's a statement that adverse results would not be used in a punitive way or result in discharging a patient from the practice.
So what would happen with inconsistent results? Because I mean, I just think punitive is a little vague. If there's two, or at what point is a practitioner able to say, hey, and my concern is that an inconsistent screen can mean these controlled substances are being diverted, which places the public at risk, or stockpiled by somebody who may have be at risk for suicide. And so the practitioner needs to do something to take responsibility about the controlled substance that's being prescribed on their authority. I mean, maybe if it's said on the basis of a single inconsistent, urine drug screen.
So this particular language is something we pulled from the CDC guideline. It's very similar. I mean, it's a little bit different, but it's very similar from what's in the CDC guideline already. And that's why they chose to use this particular language.
Can you show me the other part that was changed after the last draft?
So the only other thing we've done since the last draft is add back in this biological testing in in sub 1 of the section here, which is for physician assistants, and then the same will happen in the MD one.
Physician rule.
Mm-hmm.
Is it considered punitive to discuss with the patient? If you have another one of these, you might be discharged from my practice. Is it punitive to say, I'm not okay with this, I need you to bring in your pills for a pill count? I'm sorry, I just think punitive, even though the CDC says it, is kind of broad.
And I
If
think
our-
it's
our
broad
position is-
for a reason, Kristen, but discussions that we've had in the commission regarding complaints have very much shifted from you have a negative urine such that diversion is presumed, or you have a urine that's contaminated with something that wasn't prescribed to you and patients are being discharged. Now it's more like, you know, the marriage where both parties say, I'm not leaving and you're not leaving. You know, we need to work this out together. And opening discussion is not punishment. It's opening discussion and allowing the patient to become the partner they need to be in their care. So we've seen some, you know, in real life cases that we have discussed, you know, without revealing what they are, we have seen practitioners use that as a real opportunity to make the patient feel safe to disclose what's really going on so that they can be helped to the greatest extent the practitioner can help them. And they haven't been discharged.
So if you're a physician who's had complaints against you and we're reviewing it for charges and an expert reviews the case, aren't they going to read this rule change to say, well, no, I didn't follow up because I didn't want to be punitive and your rule has changed. So no, that's why I didn't take further action in response to inconsistent urine drug screens. So I understand the complaints you get about people being kicked out of the practice, and I understand the conversation that should be occurring in a discipline process. I think this creates some vagueness. So, I mean, you've heard my comment and you can do whatever you wish with it, you know.
Well, we appreciate your comment.
Thank you.
As you know, some of these statements are vague for a reason because we can't anticipate the multitude of different presentations or complaints or complications in this special patient population that we're trying to address and help.
Sure. And I only review the language in the context of when we're doing litigation for a case, which is a very, you know, specific setting. And I understand it isn't the only concern that the commission has in terms of the language that needs to be used in a rule. I just want to point out the way it gets used in litigation is, this is why I didn't do it. You shouldn't hold me responsible. This is my defense.
Thank you.
Thank you.
Are there any other comments or questions? Are you hearing any, Amelia?
No, there's no hands raised. No, I don't see anything, and there's nothing in the chat.
Okay. So now Ms. Boyd will discuss the next steps.
I'm getting there. Hold on just a second. Okay, so our rules development timeline is as such. The next step would be to bring this language that you've revised today back to the commission, and then at their July meeting, we will request to initiate the formal proposal for this rulemaking, and then hope that we are able to do that. And if it gets approved, then we will hold a public hearing, hopefully in October at the business meeting on the 11th of October. And then the next step in the rules process, which is permanent rule with the CR 103, then we would adopt the rule, and then there would be a concise explanatory statement that would go out. And then the rules should be in effect early next year, or that should say 2025, not 24.
Okay.
They should go into effect early next year. That's if we stick to this timeline. If there's a delay, then obviously it would be more like spring before they would be in effect.
Is there anyone else who wishes to comment? Do you see anyone, Amelia?
No, I don't see any hands raised, and doesn't look like anybody is unmuting.
Anything else that the other two commissioners would like to add?
I look forward to another conversation at a later time.
Thank you, Mr. Lopez. No one else, Amelia? That you
Doesn't appear
see?
to be.
Hey, if there's no one else who wishes to speak, I will close the workshop and thank you all for your participation. We really appreciate it.
Thank you, everyone.